So let's continue on looking at what's going to actually regulate the passage of materials through the alimentary canal, as well as the regulation of digestion of the nutrients. So we have two really areas of centralized control. One is going to be neurological, and the other one's going to be hormonal, just like with every other part of the body in terms of homeostatic regulation. The neurological side is going to be from the enteric pathways, in which we're going to have two distinct plexes of regulation. We'll have the myenteric motor plexus as well as the submucosal sensory plexus. We will also have the autonomic response coming on here based off of extrinsic pathways between parasympathetic and sympathetic activity, where parasympathetic activity will increase the relative rate of gastric motility and digestion, whereas sympathetic activity will decrease the relative rate of gastric motility and digestion. The other side of the control that is going to come into play here is going to be hormonal, where just like with every other hormonal response, we'll see an endocrine, a paracrine, and an autocrine regulation. These regulations here in terms of hormonal regulation is going to regulate the rate at which digestive enzymes and digestive juices are being released, as well as the rate of postprandial absorption based off of signals coming primarily from the liver as well as from the pancreas, with secondary signals coming from adipocytes as it relates to the regulation of feeding. So when we look at this regulation pathway, we basically lay out within this schematic here where we're going to have the interactions within the enteric reflexes of the myenteric plexus and the submucosal plexus, which is going to regulate the sensing of nutrients as well as sensing of chemicals within the alimentary canal, as well as the rate at which peristalsis will be allowed to progress based off of reflexive regulation of the smooth muscle within the mucosal layer, the muscularis layer of the luminal tissues of the alimentary canal. The sensory pathways will go ahead and lead into relays into the autonomic as well as into the central nervous system pathways. We're going to have secondary signals coming from the hepatic portal system. The hepatic portal system has metabolite sensors, which are very similar to the gustatory centers that we see within the oral opening. The hepatic portal system receptors here are going to be sensitive to 6-carbon and 3-carbon sugars particularly, so as to regulate the postprandial responses that we see coming from the pancreas, the liver, the adipocytes, the skeletal muscles, in terms of what nutrients will be utilized for energetic purposes and what nutrients will be anabolized into larger macromolecules for storage purposes. When we talk about the regulation of the pathways here, it's about what's referred to as motility. And motility begins with the contractions of the circular and longitudinal muscles within the esophagus, following glutination, following swallowing. That will lead into the stomach. In the stomach, we have a slight difference in the coordinated contraction between the longitudinal and the circular muscles. That is going to slow down the rate of motility through the stomach so as to allow for full acidification of the materials that will lead to liquefaction into the chyme from the bolus. The rate of motility is going to be regulated based off of the materials that are being digested, the regularity that those materials are being seen, and any type of myenteric efferent activation through regulations by autonomic nervous system. Now, when we talk about the regulation based off of materials, what we're talking about is, does the secreting cells that are going to be producing the digestive enzymes produce those digestive enzymes? If they're not producing those digestive enzymes, those cells basically start to slow down their normal metabolic activity, which will reduce the rate at which those new nutrients are being digested. The more stuff we have within the alimentary canal, the faster motility will take place. the more materials that are there, the faster motility and the less digestion will take place, leading to a larger volume of fecal matter at the end of the digestive process. So peristalsis is the coordinated actions that take place between the longitudinal and the circular muscles based off of the stretch reflex, either from the bolus or from the chyme of food as it enters into the lumen of the alimentary canal, in which the circular muscles will stretch, causing them to compress, doing a ring squeeze around the bolus, which causes a stretch in the longitudinal muscles, which causes a compression, which causes a stretch within the circular muscles. And so we get this squeeze, compress, squeeze, compress, squeeze, compress wave of motion within the muscularis layer of the alimentary canal that will constantly be propelling the food, the bolus or the chyme of materials being digested in a forward motion, meaning it's always attempting to move from the mouth to the anus. This begins with swallowing and terminates with the defecation reflex, leading to the elimination of fecal matter. Now, what ends up happening is that when we get to the stomach, we slow down this rate of peristaltic motion, allowing for increased activity and increased interaction between the digestive enzymes and solutions and the food materials itself. The motility that we see within the stomach is going to be referred to as gastric motility. The motility within the esophagus is referred to as esophageal motility. The motility within the intestines is referred to as intestinal motility. The rate at which motility is taking place is based off of the regularity at which we're seeing the food materials, and this regularity of food materials is going to dictate the rate at which contractions are taking place based off of the reflexive loop between the enteric submucosal plexus and the myenteric plexus. Within the stomach, what ends up happening is that there's a tertiary layer of muscle. And the tertiary layer of muscle is at an oblique angle to the longitudinal and the circular. And what ends up happening is that based off of the oblique layer firing, we end up getting this kind of circular action within the stomach. The circular action within the stomach leads to a regurgitation wave within the peristalsis. This regurgitation wave within the peristalsis leads to what's referred to as retroflow. There's a special anatomical region within the stomach, the fundic region, that allows for this retroflow to take place without having reflux into the esophagus due to the coordinated contraction of the sphincters during the peristalsis that doesn't allow for the bisphincter, esophageal sphincter to open when material is in that region. Now, regardless of what you've been told, the stomach itself will empty in terms of material in about a half hour, hour at most. The area of the fundic can hold material in it for about 20 minutes. So that gum that you swallowed when you were 7 years old is not still in your stomach regardless of what your mother told you. She simply didn't want you swallowing the gum. As material starts to be digested down, its density starts to change relative to the surrounding materials, and what happens is it slowly starts getting propelled towards the pyloric region of the stomach and then eventually out through the pyloric canal in the pyloric sphincter. And the pyloric sphincter is very narrow in diameter, and once again, just like with the esophageal sphincter, we have a bisphincteral layer, which means we have two sphincters that are going to be controlling the action at the pyloric sphincter, so as to control the rate of material moving into the duodenum so that we can neutralize the material at a fast enough rate so as to not cause etching of the mucosal layer within the duodenum of the small intestine. So what's going to regulate the rate at which stuff is moving through the stomach? So we have basically three things that are going to be regulating the material rate moving through the stomach, as well as the acidification of materials. Part of it has to do with how much is being consumed. The other part is that we're not actually going to be absorbing a whole bunch of material. Most of what is occurring within the stomach is liquefaction of the digested material. What can be absorbed is anything that is going to be membrane soluble. The most prominent thing will be absorbed within the stomach are ethanols. But once again, most everything is going to be passed along in the chyme that's going to be exiting the stomach. So what are the things that are going to be regulating the stomach acidity? Well, we have parasympathetic control that will be regulating. We have 3 distinct hormones, gastrin, secretin, and CCK. And then once again, how much are we consuming? So let's take a look at the hormones here at play. So gastrin is regulated by higher cortical input as well as what's referred to as gastrin-releasing protein, GRP. So as we start to eat, or as we start thinking about eating, we start having changes of gastric metabolism. And what this does is this starts to allow for the stomach to distend. As we start to eat itself, food starts to drop into the stomach through peristaltic contraction, and this reduces the overall acidity of the stomach by having more things within the stomach, reducing the concentration of hydrogen ions from hydrochloric acid. This is going to stimulate the production of gastrin. As gastrin gets produced, it's going to inhibit the gastrin-releasing peptide, gastrin-releasing protein. But what it's also going to do is it's also going to increase overall gastric acidity by increasing the rate of hydrochloric acid being produced within the gastric pit. Gastrin is going to head back upstairs to the hey dummy areas, and it's going to say, please stop putting stuff into your gullet. We need time in order to digest down the food bolus into chyme so we can go ahead and further do chemical digestion. As GRP gets produced and gets inhibited by production of gastrin, it's going to also be reducing the rate of feeding, once again, because we want to make sure that we have the correct amount of acidity within the stomach. As the gastric acidity starts to increase, as pH within the stomach starts to decrease, we start reducing the level of gastrin that's being produced. And so what cells are going to be involved here? Well, for our gastrin, we're going to get the G cells at the gastric pit. For the gastric acidity, we're going to get the parietal cells that are going to be involved. And so that's one of the feedback loops that are coming into play. The next feedback loop that's going to come into play is going to be related to the rate of gastric emptying and the necessity to neutralize the material as it enters into the duodenum. And so once again, we start feeding. As we start feeding, we're going to start increasing the rate of gastric motility and motility through the alimentary canal. As we start getting more acidic materials exiting the pyloric region, CCK starts being produced. CCK is going to do 2 things. Number 1, it's going to head back upstairs to hey dummy and says, please stop putting food in your gullet. We need time to digest down and neutralize the stuff exiting the stomach so we don't damage the intestines. It's also going to increase the rate of activity from the gallbladder in terms of secretion. It's also going to increase the rate of pancreatic acinar cells in terms of the rate of excretion, both of which are going to end up increasing the rate of bicarbonate going into the duodenum. As bicarbonate goes into the duodenum, it starts to inhibit CCK release. So that is gastrin and CCK in terms of reducing or elevating the level of acidity. So what's going to look at the rate of secretion of hydrochloric acid? Well, as we start to increase gastric acidity and empty, we need to somehow control the rate of hydrochloric acid being produced. So inhibition of gastrin is going to help that out. But we have a secondary hormone that's going to come into play, and that is secretin. Secretin is going to inhibit the chief cell and the parietal cells from producing pepsin as well as producing hydrochloric acid. By reducing the rate at which pepsin and hydrochloric acid are being produced, we're going to reduce the rate of gastric acidity. Hopefully enough reduction of gastric acidity so as to maintain normal gastric acidity when we are not having a distension of the stomach. So as the stomach starts to slowly empty out, as it starts to collapse down, we start increasing secretin because we don't want to overproduce acids. The overproduction of acids will overload the mucus producing cells at the surface of the gastric pits and can lead to ulceration of the stomach. So the other functional areas within the alimentary canal include the small intestines and the large intestine. The small intestine is going to be the primary site for both chemical digestion and absorption. We have a super huge amount of surface area within the small intestine as when we combine the villi and the microvilli within the mucosal layer. The motility that we see heading through the small intestine is entirely based on the amount of material that is there and what components we are sensing within the food. If it is something that we are not normally eating, material will pass through quite quickly because we do not have the digestive enzymes to digest it down, and we do not want that material sitting within the small intestine, as it's going to slow down the rate of digestion of materials that we normally are going to be eating. Within the jejunum and within the ileum, we're going to be having a large amount of absorption, either through facilitated transportation or through active transportative mechanisms. In the large intestine, we're not going to get a whole bunch of digestion. Most of the digestion that takes place within the large intestine is due to the microbiome that exists within the large intestine. Primarily, we're going to be doing a lot of reabsorption of water. This is the last chance to get any absorption of water, particularly within the sigmoid colon of the large intestine. The last third of the intestine itself, the lower part of the descending colon, the sigmoid colon, and the rectum is where we're going to be forming the compaction of the fecal matter through constant reabsorption of water and electrolytes. The amount of bacterium that we see within the large intestine is going to dictate the looseness of the fecal matter due to inflammatory processes not allowing water to be reabsorbed. Overall movement through the alimentary canal is based off of factors that relate to the regularity of the materials that we're consuming as well as the volume of materials that we are consuming. However, we should be completing somewhere between 2 to 3 full waves of peristalsis every 24 hours every day. Each wave is going to lead to a rectal reflex or a bowel movement. This pathway is done so as to ensure that we are forming the correct amount of fecal matter, and the consistency of what we are eating allows for reabsorption of all of the liquid that we pumped into the alimentary canal, as well as absorption of any of the materials that we need for normal metabolic processes. The overall rate is going to be controlled by things such as fiber, the amount of water that we are consuming, and any bacterial byproducts. If we have too much bacterial byproduct, we're going to start collecting too much water within the alimentary canal. More water in the alimentary canal means things move faster. And the materials within the diet. The more regular the material we are seeing, the more regular the waves of peristaltic motion will take place. The more novel something is, the more new something is, the faster materials will be moving through so as to ensure that we are not backing up or allowing the microbiome to become hyperactive. The last part of the movement of materials through the alimentary canal is what's referred to as the rectal reflex. So the rectal reflex, just like the micturition reflex, is underneath a combination of parasympathetic and sympathetic regulations that is regulated hyocortically, where we will send signals to the external anal sphincter that basically says, do not relax, do not relax, do not relax. We learn this regulation within about the first 2 years of life, with full mastery around 5 years of age, and we slowly start losing it as we age, just like with the loss of the control of the urethral sphincter with micturition. In terms of what we see within the feces, it's going to be anything that is either not digested or not absorbed. So there's a difference between not digested and not absorbed and undigestible materials. Not digested, not absorbed, and undigestible materials are two wholly separate things. Just because we digest something down doesn't necessarily mean that we're going to be absorbing it. That is digested, non-absorbed materials. Different than that is non-digested materials. Non-digested materials are things that we cannot digest because we don't have the enzymes or the microbiome is unable to digest it down. We will also see things like water and electrolytes, mucus, and bacterium. The mucus and bacterium is what's going to give fecal matter its color, its odor, and a majority of its mass. So what's going to be the regulations of motility? Well, number one, the food materials, and this is where we're looking at the type, the amount of non-digestible materials that are being consumed, the amounts of material that are being consumed, what our level of autonomic tone happens to be. If we're really stressed out, we're going to be slowing down the rate of gastric motility because we're not going to have the correct level of parasympathetic tone to keep gastric motility high. Hydration level. If we are dehydrated, we're going to be overly compacting the materials, absorbing a whole lot of water, and that's going to slow down the rate of material. If hydration level is severely impacted, it can lead to issues of constipation. And so whenever we're looking at gastric motility, one thing that we always have to look at and think about when we're talking about this related to our patients and our clients is how is diet going to impact